Hello, I'm Paul Evans and welcome to Airing Pain, a programme brought to you by Pain Concern, the UK charity that provides information and support for those of us who live with pain. This edition's been made possible by Pain Concern supporters and friends. More information on fundraising efforts is available on our Just Giving page at painconcern.org.uk.
I went to the Ideal Home exhibition a few years ago, and the man selling the beds, he says, "Excuse me, sir." Yes, he says, "You've got ankylosing spondylitis. Would you like to buy a bed?"
Some GPs are fantastic and others don't know an awful lot because their training in dermatology has been cut, and some of them have got about 2 weeks dermatology in 6 years.
We did include the vets in our survey, and the vets on average did have a higher pain education in terms of the number of hours compared to those being educated on the human healthcare side of things.
And so I know it's nothing, but you know what I mean. What I'm saying, he knew just by looking at you, and you know what I mean, that was just a man selling beds.
More about GP training and top tips on medical diagnosis from a bed salesman later. Now, ankylosing spondylitis, or AS, is a condition where some or all of the joints of the spine fuse together. It's one of the three most common forms of inflammatory arthritis, along with rheumatoid and psoriatic arthritis. They're separate conditions, but what each has in common is that the body's immune system is wrongly triggered to attack itself, causing pain, stiffness, damage to joints and, if left untreated, possible disability. It affects around 200,000 people in the UK, and I met Iain MacDonald and Tom Downie, Secretary and Treasurer of the Edinburgh branch of the National Ankylosing Spondylitis Society. Tom was a teenager when the disease took hold.
I was at boarding school, and we'd be playing football or something. Next day, I just couldn't move out of bed. I just seized up, just couldn't move. And the nurse would come put some deep peat or something on, and I'd be fine a few hours later. And that went on through my school years. But as I got into my 20s, I'd get the deep peat on, but I would still be there for 3 or 4 days. And I got, as I say, mid-20s, out of action for weeks, just not being able to move and getting all the painkillers and things. And although it maybe takes some of the pain away, you just couldn't move, you were that stiff and things. And I never got diagnosed till about maybe 30-year-old. And by then I was away, stooped over, I couldn't see where I was going. I mean, life was just hell. And you get depressed and things like that. And I say I got my hips replaced when I was 35, and that made a big difference in constant physio and things. So now I can walk about any distance. I need a walking stick, but you know what I mean, life's all right.
Working at the maths, it took 15 years to be diagnosed.
Yes.
Why was that?
I say I was 15, 16, I was at school, and you were seen as there's Tommy wanting to get off, doing something, just wants to stay in bed. And when I started working, I would go to work, and I say 18, 19, you'd have to have a week off here and a week off there, and you just couldn't do things. And when you're that age, you don't want to go to the hospital, or you don't want to go to the doctor. But eventually, when you do, you just get diagnosed with lots of different things. Oh, it's stiffness, it's juvenile arthritis, it's this. And I'd be in my late 20s when actually somebody says, I think it's this, ankylosing spondylitis, and further investigation.
If you were a 15-year-old now going through it, would it still take 15 years?
Well, no, I've got a son who's 22, and when he was 13, he went through the same sort of thing. He was told he had some kind of juvenile arthritis, and he would have days off school and things like that, and he had to carry on, and he, unlike me, liked school, so it was quite a problem for him. But me already having it, went to a doctor, got diagnosed really quick and got offered physiotherapy, so within 2 years or something, he was getting offered physiotherapy, but I wasn't getting offered physiotherapy for 15 years.
So has he had a successful diagnosis because of your knowledge, or has it moved on?
Well, I think about it both. At first it was because of my knowledge. With the group we go to on a Monday, you do hear and you see younger people coming now, not very often, but you see them, they seem to be getting diagnosed in their 20s and now, but it would take maybe me and Iain 10 years before we had it. So they do seem to be diagnosed a lot quicker.
As an organisation,
Yes.
the National Ankylosing Spondylitis Society,
Yes.
what are you doing to help people get better treatment or more information?
Yeah. Tom and myself and another colleague, Campbell Barr, have been going along to the Scottish Parliament for the last 3 or 4 years to various committees to try and get the publicity such that ultimately the information gets spread. The members of the society get three principal things. One is interface with fellow sufferers so that they get information on potential problems and perhaps how to cure them. The hydrotherapy sessions that we're lucky enough in Edinburgh, and gymnasium sessions, so we get an exercise regime that will help at least keep the problem at bay, not necessarily cure it.
Also, I think that if people know about the group and they go earlier, you can get the information. So, as somebody like me who got hip replacements in their 30s, and so I've got a son who's 22, with him knowing about ankylosing spondylitis, because even something like as simple as posture, you find out all that information, so you can avoid problems like having to get hip replacements and that, with the right physio, the right exercise, the right medication, where you can stay and work longer and things like that.
Talking about your son having it as well, is it hereditary?
Yes, well, we've been told, I don't know the official statistics, but I'm just going by me. I've got 3 sisters, and one of them's got ankylosing spondylitis, and another one's got psoriasis. And there's a connection between psoriasis and ankylosing spondylitis. And my son's got AS, but to see him, you wouldn't know. I mean, he looks fine, he looks fit. But at least with me knowing these things, you know what I mean, I can go on there when I see him watching TV slouching. I can go on it, we sit up, and it can, as I say, it can avoid problems in your 50s and 60s. It's something that you can do now.
I can confirm that it is hereditary. My father had it, and I have 4 sisters, one of whom has also got it. We're keeping our fingers crossed. I've got 3 kids, and that we have no sign of them actually having the problem yet. So as Tom says, I'm 2 out of 5 got it, so we're keeping our fingers crossed that our kids.
What advice would you have for somebody who's just been diagnosed with ankylosing spondylitis?
I would ask them to find a local NAS branch, and there are many throughout the country, and gain the benefits that I personally gain from it. Speaking to people who also have the problem, finding out what their problems are, and perhaps helping you, getting the hydrotherapy sessions, the gym sessions. In my personal circumstance, Campbell Bar, who I've mentioned before, actually had physiotherapists organised to do measurements. There's a system called a bath system that actually measures your degree of stiffness and pain. There's a 3-sheet set of statistics that people can measure how badly you are or otherwise. And it was thanks to this measurement regime that then got referred to the rheumatologist. So I gained huge benefit personally through going along to the NAS organisation branch in Edinburgh.
And Tom, on a day-to-day basis, what advice would you give somebody who's just been diagnosed with ankylosing spondylitis?
The key is keep moving. As Iain says, on the Monday night, we've got half an hour in the hydrotherapy. We're trained physiotherapists, they know what they're doing. So that makes a difference. You get that hydrotherapy on the Monday, and then through in the gym, 45 minutes of light stretching, you go at your own pace. And once you get into that routine, you're doing that, I just feel that it just sets you up for the rest of the week. Even a jacuzzi, you know what I mean? Before you go in jacuzzi, you might be able to walk 25 steps without a seat. But once you've been in that jacuzzi, you can maybe walk 100 without a seat. Movement is the key.
Tom Downie and Iain MacDonald, and you can find more information about ankylosing spondylitis, including details of the local branches of the National Ankylosing Spondylitis Society, from their website, which is nass.co.uk. That's nass.co.uk. Now, I mentioned the link between AS and psoriasis, or psoriatic arthritis. Janice Johnson helps run a small Scottish charity, PSALV. It stands for Psoriasis Scotland Arthritis Link Volunteers.
I myself have psoriatic arthritis, which I've had since 1974, diagnosed in 1974. Unfortunately, wasn't given good treatment back in the 70s and 80s, And there are now a lot of newer medications available. There's no cure. It's similar to rheumatoid arthritis in some ways, in as much as it's an inflammatory arthritis. But back in the 70s, and for 25 years after I was diagnosed, I wasn't given anything other than non-steroidals, and I should have been given second-line medications. So for 25 years I had little flares and been left with quite a lot of damage, which is not reversible other than with surgery. It's similar to rheumatoid in as much as if you can get in quickly with the diagnosis of this, you can treat it. You can't cure it, but you can treat it. Osteo is more difficult actually because it's wear and tear. But with the inflammatory types, if you can get in early, you can do more. So that's basically what happened to me. But I do have a lot of pain and a lot of stiffness, and I can't walk very far now because I've got a lot of tendon damage, ankles, feet, knees. So my mobility is not good.
Now, lots of people might know about psoriasis, but not know the link between psoriasis and arthritis.
Psoriasis is an overgrowth of skin cells, but there's also an inflammatory response. And you don't have to have a lot of skin psoriasis, which is red scaling patches, to have problems with your joints. This is part of the problem. You might have a tiny little bit of skin psoriasis, even just a tiny little bit, and then develop sore fingers and toes is one of the most sort of classic ones. And unfortunately, GPs, like a lot of things, are not terribly well trained in spotting this. And the link is the inflammation. The inflammation, for some reason, in about 1 in 5 people with any skin psoriasis, not necessarily extensive. It doesn't have to be, you don't have to be covered in psoriasis to get this. Develop some problems with their joints. And again, it's very variable. It might be one finger or you can be in a wheelchair. So we're not trying to frighten anyone, but it is a progressive thing, so that you do need to treat it early. Some GPs are fantastic and others don't know an awful lot because their training in dermatology is being cut, and some of them have got about 2 weeks dermatology in 6 years, which is ridiculous.
So what should people look out for?
Well, anyone with diagnosed psoriasis should be aware of this, not to frighten anyone, but if you get a swollen, especially a sort of swollen, puffy finger or toes, or, well, actually pain in your heel. The heel's another common place. Back of your heel, sort of tendinitis. You should go and ask your doctor if you can get a referral to rheumatology and just see what's going on without terrifying anyone, because it might be something else. Don't get terrified. You think, oh my God, I've got a bit of psoriasis. Just, keep an eye on it.
Well, I'm glad I'm speaking to you because I have a little bit of psoriasis and I will keep an eye on it.
No, you're terrified. Bear in mind, most people with skin psoriasis don't get problems. As I say, it's about 1 in 5.
Well, you've been rummaging through your bag and I've got exactly what I need, which is a leaflet from This is Psoriasis. I must read this, and thank you very much indeed.
Thank you very much. Thank you.
Janice Johnson from PSALV, that's Psoriasis Scotland, Arthritis Link Volunteers. She and the previous speakers made reference to the adequacy of training for health professionals. Sue Clayton has been involved with pain concern for many years. Having had chronic pain for over 30 years, she was invited to give the patient perspective to health professionals at the 2011 annual scientific meeting of the British Pain Society.
The model where someone has acute illness, they're treated, they're discharged, is a sort of condition governments are interested in because they get a pathway, they get an outcome that they can measure. Chronic pain is a very different sort of condition. It's a long-term condition. People have probably got it for the rest of their lives, unfortunately. And I think it calls for a different sort of relationship with the clinicians that the patient is working with. In a way, a much more caring relationship. And I think one of the hardest things that patients like me are facing at the moment is in the way that medical services are changing, is that patients like me desperately need continuity of care with their medical advisors. And that is what is being lost in the health service at the moment. It doesn't make sense for me to have to go into my general practitioners and be prepared to seek anybody of the 5 GPs who work there, and have to repeat my story endlessly so they understand where I'm coming from. They have doubts usually because of some of the drugs which I'm on, whether this is suitable, whereas my much lamented, splendid GP who's recently retired, because she'd known me for 20 years, we'd built up a relationship and she trusted me. I trusted her to give me the best available care that she could manage. But she also trusted me. She knew that I didn't swing the lead. She knew that I took my drugs responsibly. She knew that I put effort into self-management. She knew that if I came to her and said, things have got much worse, I need help with a particularly difficult period, a bad flare-up, that was genuine. I wasn't making it up. And she only knew that because she'd known me for a long time, and known me over a period of time. That's being lost. And that makes it very difficult for GPs at the cold face to work with people with long-term conditions like chronic pain, because they're complex, pain is subjective, it's invisible. In a sense, they have to take an awful lot on trust of what their patients are saying. And how can they have that trust if they haven't built up a relationship and a knowledge of their patients? So at the moment, it's very, very difficult, I think. There needs to be a huge amount more training going into for clinicians dealing with chronic pain, both right from the undergraduate level right up to specialists, to understand that patients really struggle to cope with their lives, and that a lot of them are really doing their best, but that often life is extremely difficult, and also pain fluctuates so much. You may go along fine for 6 months and then wake up and for some unknown reason you have a terrible flare-up. This is what happened to me 3 weeks ago. Nothing that I could put my hand on. People say to me all the time, "Oh, do you know what happened?" And I say no. And that makes it very difficult for the patient, because they don't know what to avoid, they don't know how to manage better. If there was a trigger, I know that if I do something really stupid like dig the garden, of course I'll have back pain, but it can happen without any warning at all. And this makes it so difficult to explain to clinicians and for them to believe you, because perhaps they've seen you out and about and you look perfectly all right. I mean, most people seeing me think I look perfectly normal. They don't know that sitting here today, I've got searing, burning pain from my waist to my toes. It just isn't visible. How do you judge somebody like that? It's a very, very difficult situation, both for doctors and for patients. And so I think there really has to be a model where patients have continuity of care in a relationship where they trust the doctors to actually believe what they're saying, accept it, and be prepared to perhaps put the barriers down a little bit, treat them as human beings who are capable adults who are trying to lead their lives as well as possible. Nobody wants to be in this situation. They've had it forced upon them. I would give anything not to be living like this, but I have to. It's very easy to judge people with chronic pain and judge them very unkindly. And that happens both from the general public and from clinicians and other health professionals at times, to take things on face value without actually talking to patients and finding out what's going on underneath.
So Clayton, who spoke at the 2011 British Pain Society annual scientific meeting. In the following year's meeting, I spoke to Emma Briggs. She teaches at the Florence Nightingale School of Nursing and Midwifery at King's College London. She's also chair of the British Pain Society's Pain Education Special Interest Group. Their aim is to enhance the education of qualified health professionals and the patient education that they provide. So why should healthcare professionals who've been through years of training need this?
Very good question. We recently conducted a survey that we published within the European Journal of Pain, which looked at the amount of education that was provided to our undergraduates, and that looked at the education that was given to dentists, to nurses, doctors, midwives, physiotherapists and pharmacists. And the number of hours of education that they receive is actually very low. The average hours for a midwife was 6 hours in the whole of their curriculum. Nurses receive an average of 10 hours, doctors an average of 13. The overall average was 12 hours of education.
And you're talking about education, about pain issues.
About pain, yes. And considering it's the reason that people seek healthcare and the amount of pain that people have experienced, that's a relatively low number in their curriculum. So it's less than 1% of their curriculum actually includes pain management. So we are trying to increase the number of hours devoted to pain management, but also how it's taught within our universities within the UK.
You missed out one category in your list, and that's vets.
Vets, yes. Now, we did include the vets in our survey, and we replicated this survey from Canada, and there are 5 vet schools within the UK, and unfortunately we only got two respondents. But the vets on average did have a higher pain education in terms of the number of hours compared to those being educated on the human healthcare side of things. However, we can't, it was only 2 schools, but it is a surprising statistic that they have a higher number of hours in their curriculum. But that comes down from their regulators. They're the regulators of the veterinary undergraduate programmes stipulate that pain should be in there, and then the quality assurance body that follows that up to make sure that education is being delivered well, they say that pain should be in there. So they kind of attack it from both sides. Whereas we, as part of the survey, we looked at whether healthcare regulators such as the Nursing Midwifery Council, the General Medicine Council, whether they had made those stipulations. And in some cases they had, but in many cases they hadn't. So we really need to tackle things from the regulators so that they encourage and stipulate that pain should be in the curriculum.
It's hotly rumoured that there's an event this summer called the Olympics.
Yes.
You've managed to get it into one of your titles as well.
We have indeed, yes we have, and in fact our workshop today was called Citius Autius Fortius, and launching our Olympic campaign for pain education. And that was really about saying there's been some great developments about pain education for healthcare professionals, for patients and the public, and it's saying, but actually we need more, and we need to be higher, faster and stronger on this, and we really need to push the agenda. One of my lines within the workshop was, we haven't got a £2 billion development fund, neither have we got a one-eyed mascot, but there is much that we can do collectively to really move this agenda forward. And we've been working with a number of people, and from that workshop some great ideas have come out, and we will be sort of rolling those out to kind of improve pain education over the coming months.
What sort of ideas?
Well, we have the Interprofessional Undergraduate Curriculum document coming out later on in the year. So that's a working party that's being chaired by Dr. Nick Alcock. And we are looking at producing a document which really helps people put pain education into their curriculum. Because people can face a number of barriers. One fellow academic said to me, but my head of department has said, I have got a number of penguins on my iceberg. Which one do you want me to push off in order to get a fit pain in the curriculum? And we want to change those sorts of attitudes to say, we don't need to push off any penguins. We need to make sure that each penguin knows how to manage pain. They've got the skills to do that. So this document is a real sort of practical how-to help the person champion pain management within their university. How do you integrate it? How do you try and get healthcare professionals learning and working together? Because the reality is, in clinical practice, nurses, pharmacists, doctors all need to work together to help the patient. But at the moment, our survey has shown that they don't learn together. They learn separately on their courses, and we need to change that. So this document is very much about saying, how can you get healthcare professionals learning with, about and from each other, so that when they qualify, they are able to work really well interprofessionally and for the best interest of the patient, really.
Tom, do you find that doctors find difficulty in diagnosing your condition?
Oh, years ago, yes, but younger medical students and younger they can look at you and some of them just see you walking in the room and think ankylosing spondylitis. I went to the Ideal Home exhibition a few years ago, and the man selling the beds, he says, "Excuse me, sir." Yes, he says, "You've got ankylosing spondylitis. Would you like to buy a bed?" You know what I mean? And so I know it's nothing, but you know what I mean. What I'm saying, he knew just by looking at you, and you know what I mean, that was just a man selling beds. And I think as well, younger students, they can see you, but that can be a danger as well, because somebody like Iain, who, although his neck's stiffer than that, he's not stooped over like me. So just because you're not stooped over, you can still have ankylosing spondylitis.
But you were telling me earlier that you get involved in training doctors and even consultants.
Well, yeah, it's just called the Exemplar Patient Programme, and it's third and fourth year medical students. We spend an hour and a half in the room with them, talking to you, and they want to know how you were first diagnosed and that, and how you feel your GP in particular dealt with your problem, and how you feel it could be improved if they become a doctor in 5 year time and somebody walks in with a sore back, how could it be improved?
So, in short, you go along to the hospital as an exemplar patient. Yeah. A group of doctors, young and old, come in and they have to work out what's wrong with you.
Well, yeah, as I say, as you go down there, there's maybe 4 or 5 other people like me, and we get put in the 5 rooms, and this group of students, there'll be 4 or 5 groups of students, and their job is to try and guess what's wrong with that person. And there'll be me with ankylosing spondylitis, somebody with rheumatoid arthritis, somebody with other forms. And I have noticed over the years of doing this, they seem more informed than the doctors were 20 years ago, put it that way.
So, of the consultants, the student doctors, and the double bed salesman, who gets the best training?
I think the young doctors, the 4th year students seem to be more with it now than ever before, in my opinion anyway.
The big thing about pain education is that all the information and the help is there, but we just don't know it's there.
Yes, yeah. It's very true, actually. Dorothy Helm, who is our link with the Patient Liaison Committee and is a co-opted member of the Education SIG, was reflecting on that point this morning when she was telling her journey from when she first started experiencing pain to her diagnosis. She was saying, I am a nurse by background, but I am a pain sufferer. And I did not know where to look, and there was not enough information out there for me. Couldn't find the information. I hadn't even found the information from the British Pain Society. So again, there's a lot to be done there in terms of awareness and helping people find the appropriate and well-informed information resources for them, and support groups and specialist support groups as well.
Emma Briggs, Chair of the British Pain Society's Pain Education Special Interest Group. Now, don't forget that you can still download all the previous editions of Airing Pain from painconcern.org.uk, and you can obtain CD copies from Pain Concern too. If you'd like to put a question to our panel of experts or just make a comment about these programmes, then please do so via our blog, message board, email, Facebook, Twitter, and of course pen and paper. All the contact details are at our website. Once again, painconcern.org.uk. Our usual words of caution are that whilst we believe the information and opinions on Airing Pain are accurate and sound, based on the best judgments available, you should always consult your health professional on any matter relating to your health and well-being. He or she is the only person who knows you and your circumstances, and therefore the appropriate action to take on your behalf. And that goes for information and guidance you'll find from other sources, particularly the internet. Emma Briggs to close the programme.
The internet is a fantastic resource, but it can also contain some very unreliable information, and in fact Dorothy was reflecting on her experiences of using the internet and finding very negative information on the internet, which was not helpful for her as she was searching for some help for her facial pain condition. And it's very difficult to judge. I mean, the students that I work with, they have a whole programme on how to use the internet effective to actually make those judgments as to who is it written by, when was it last updated, what was the purpose, was there any advertising around with it that might be influencing the writing on it. It's very, very hard to actually judge whether this is a kind of reliable source of information, and actually whether the person who's written it is actually a real doctor, nurse, etc. So it is a difficult judgment to make. And of course, you type your key terms into some internet searches and you may get sites which actually have paid to be top of the agenda, and so therefore they might have some certain biases as well.